What if I told you that your health isn't determined by your DNA, but by your zip code, that your life expectancy might depend less on the genes you inherit and more on where you happen to be born, live, and work? In some cities, two neighborhoods only a few miles apart can have a difference of 20 years in average lifespan. Not because of biology, but because of inequality. Hello and welcome. Today we uncovering a truth that reshapes everything we think we know about health. The social determinants of health. Why your zip code matters more than your DNA. This episode dives into how education, income, housing, environment, and social systems shape our bodies as powerfully as any medical breakthrough. We'll explore why the biggest threat to public health today isn't a virus or a genetic defect. It is the environment we've built around ourselves. From the air we breathe to the food we can afford, from the safety of our neighborhoods to the stress of making rent, the conditions of daily life decide who thrives and who struggles to survive. This is not just a story about medicine. It's about justice. Because when a zip code becomes a stronger predictor of life than your DNA, the problem is not biological, it's structural. The term social determinants of health might sound abstract, but its meaning is deeply human. It refers to the non-medical factors that influence a person's health, the social, economic, and environmental conditions into which we are born, grow, live, work, and age. These factors shape every breath we take, every meal we eat, and every opportunity we're given to live well or die early. According to the World Health Organization, the social determinants of health include 5 key domains: education access and quality, healthcare access and quality, neighborhood and built environment, social and community context, and economic stability. Together, they explain why some communities thrive while others crumble under the same diseases. Think of it this way: genetics may load the gun, but society pulls the trigger. A child born in a low-income neighborhood is more likely to breathe polluted air, drink unsafe water, attend underfunded schools, and live far from quality health care. As a result, their risk of asthma, obesity, heart disease, and depression skyrockets, not because their DNA is faulty, but because their environment is. Even something as simple as a bus route or a grocery store can determine health. If you live in a food desert, a neighborhood without affordable, healthy food options, your choices narrow to cheap, processed meals. Over time, that diet becomes disease. If your home is near a highway, constant air pollution silently weakens your lungs. If your neighborhood lacks safe sidewalks or parks, exercise becomes dangerous, not empowering. These aren't coincidences, they're patterns. And the patterns reveal a powerful truth. Health begins long before someone steps into a hospital. It starts in our homes, our schools, and our communities. Yet for too many, those environments are designed to fail them. Understanding social determinants means redefining what we call health care. It is not just about treating illness. It is about preventing it by changing the world people live in. Because no amount of medicine can cure the consequences of poverty, discrimination, and neglect. In the heart of nearly every major city, invisible borders divide the healthy from the sick, the privileged from the struggling. On one side of the highway, residents live in tree-lined streets, exercise in safe parks, and shop for fresh food. On the other side, families breathe smog, work multiple jobs, and eat whatever they can afford. The distance between them is measured not in miles, but in years of life. In Chicago, life expectancy in the affluent Streeterville neighborhood is nearly 90 years. Just 9 miles south in Englewood, it drops to 60. The same city, the same hospitals, the same country. Yet the gap is 30 years, wider than between the United States and some developing nations. This is what the social determinants of health look like when they remapped onto reality, inequality written into geography. Every day, people suffer from diseases that medicine alone cannot fix: hypertension from chronic stress, Diabetes from cheap processed food, asthma from polluted air, depression from isolation and poverty. These are not random illnesses. They are the biological fingerprints of social disadvantage. Behind each number is a life constrained by systems designed for convenience, not compassion. A single mother in a low-wage job who can afford time off for a doctor's visit. An elderly man in a rural town who must travel hours for dialysis. A child whose only playground is a parking lot surrounded by traffic fumes. These are the faces of public health failure, not from lack of medicine, but from lack of fairness. The cost of inequality is staggering. Countries lose billions each year in productivity, education, and healthcare spending, yet the true loss cannot be measured in money. It's measured in potential, the years of life unlived, the dreams never realized, the health that could have been protected but wasn't. When people die not because their bodies failed, but because their environments did, it's no longer a medical issue. It's a moral one. And the deeper truth is this: we built these systems, and we can change them. Health doesn't exist in isolation. It's produced by the structures of society, by policies, economies, and histories that decide who gets access to safety, opportunity, and dignity. When we talk about the social determinants of health, we're really talking about the architecture of inequality, the invisible design of our cities, our schools, and our labor systems that shape the biology of generations. At the root lies structural inequity, the way resources are distributed through systems that favor some and burden others. Redlining policies, for example, once segregated neighborhoods in the United States by race and income, labeling poor or black communities as risky investments. Decades later, those same neighborhoods still have fewer hospitals, more pollution, and lower life expectancy. The past is not gone. It's built into the walls. Education determines the jobs people can access, which determines income, which determines housing, which determines environment. And the cycle loops endlessly. Poor housing means exposure to mold, pests, and extreme temperatures. Low wages mean fewer healthy food options. Dangerous jobs mean chronic injuries and stress. And when illness strikes, the lack of insurance or paid leave keeps people trapped between choosing health or survival. Even healthcare itself reflects these divides. In wealthier districts, hospitals gleam with new technology and short wait times. In poorer areas, clinics are understaffed and underfunded, overwhelmed by demand. Language barriers, discrimination, and the simple cost of transportation become life-threatening obstacles. Tuberculosis reveals the cruel duality of global health. Two worlds living on the same planet, breathing the same air, but separated by privilege. In one world, TB is a chapter in a history book. In the other, it is a death sentence whispered through coughing lungs. In wealthy nations, tuberculosis has become almost invisible. Most people in Europe or North America will never meet someone with active TB. If they do, diagnosis is swift, treatment is free, and recovery is expected. But in South Asia, Sub-Saharan Africa, and parts of Eastern Europe, TB remains a daily reality. In India alone, more than 2.5 million new cases are reported each year. In Nigeria, 1 in every 3 patients goes undiagnosed. Even within single countries, the divide is staggering. It's not that the bacteria choose, it's that inequality does. TB doesn't discriminate biologically, but society does. Access to medicine, clean air, nutrition, and care determines who survives. For a moment, the COVID-19 pandemic seemed to close that gap. Both rich and poor nations faced a contagious disease that ignored borders. But when vaccines arrived, the pattern repeated itself. Wealth dictated access, and inequality decided outcomes. Tuberculosis never needed to teach this lesson again, yet the world still refuses to learn it. For decades, TB has lingered, a ghost of pandemics past. But in recent years, a quiet revolution has begun. Scientists, doctors, and activists are bringing TB back into the spotlight. In 2018, the United Nations held its first high-level meeting on tuberculosis, pledging to end the epidemic by 2030. It was historic, but progress remains slow. Global funding is still billions short each year. Yet for the first time, TB is being recognized not as a disease of the poor, but as a test of global solidarity. Hope lies in new science. The M72AS01E vaccine, developed by GSK and the Gates Foundation, showed nearly 50% protection in early trials, a potential breakthrough after a century. New drugs like bedaquiline and pretomanid are transforming treatment for drug-resistant TB, cutting therapy from years to months. Rapid tests like GeneXpert can now detect infection within hours instead of weeks. But technology alone cannot fix what ethics has broken. Without political will, even the best tools remain locked in warehouses and journals. Grassroots organizations are now leading the way. In India, survivors train as community health advocates. In South Africa, former TB patients guide others through treatment to reduce stigma. Across Africa, Asia, and Latin America, mobile clinics bring care to remote villages. The fight back is happening, but led by those most affected. What the world needs now is not a burst of attention, but sustained action. Ending tuberculosis means treating healthcare not as charity, but as infrastructure, funding not just drugs, but systems, diagnostics, logistics, education, nutrition. The story of tuberculosis is not one of ignorance. It is one of indifference. Humanity discovered how to cure TB decades ago, yet the disease still kills 1.3 million people every year. The question is no longer scientific, but moral. Knowledge means nothing without equality. The tools to defeat TB already exist, but access does not. Science cannot save lives if politics and profit stand in the way. Progress is only as strong as the systems that deliver it. TB thrives where health systems are weak, where clinics lack equipment, where poverty makes even a bus ride to treatment unaffordable. Pandemics never truly end until they end for everyone. TB has been proving this for over a century. It is the ghost that lingers, the reminder that global health cannot be divided by wealth or geography. Tuberculosis is not a mystery. It's not an unsolved riddle of science or a challenge beyond human reach. It is a mirror reflecting the moral and structural failures of a world that has learned to live with preventable death. The pandemic never ended because we allowed it to continue. This is not just a story about disease, it's a story about time, about how one infection has followed humanity from ancient tombs to modern cities. We have conquered space, mapped the human genome, and created vaccines in record time. And yet, millions still cough blood into their hands in silence, waiting for a cure that has existed longer than they've been alive. The next great victory in global health won't come from a miracle drug or breakthrough technology. It will come from the decision to act, to fund research, strengthen healthcare systems, fight stigma, and demand fairness. Ending tuberculosis is not just a medical goal, it is a moral test. Because until every person in every country can breathe without fear, the pandemic continues. If this story moved you, don't let it fade into the noise. Share this video, start a conversation, and subscribe for more investigations uncovering the hidden realities of global health. Awareness is power, and power, when shared, becomes change. For centuries, tuberculosis has thrived in the shadows. It's time to bring it into the light and end the pandemic that never ended.